you so much. Thank you so much for making me part of this, uh, evening discussion. I always enjoy these meetings for various reasons. One is that we have a very good chance to interact with our friends and people who are interested in learning the things. So I am also would like to submit my apologies for getting delayed. There was a lot of technical glitch for various reasons. So now the topic given to me is non-invasive ventilation in neonates. As a whole, if we have to discuss about this non-invasive ventilation, we can have a 3 days conference on this very specific topic. But I'll try to summarize in as short as possible. When we discuss about ventilation as a whole, what is the gold standard of ventilation in pediatrics? The gold standard of ventilation in pediatric population and beyond the neonatal age group is till very late it was SIMV mode of ventilation. Now it is assisted control mode, which is called with various names as maybe as SIPPV by some of the the ventilator present producing companies. So when we speak about the same in neonates, for invasive ventilation, it continues to be the assisted control mode of ventilation. As a whole, if you ask what is the gold standard mode of ventilation in neonates, it is non-invasive, predominantly Cpap. Of late, again, Cpap is losing its luster. More and more HFNC are being used. So if we have to begin, why do we have to understand about this? What is it when, if we have to understand a little bit about this? What is what is non-invasive when we say non-invasive ventilation? Anything without use of any kind of ventilation, without use of endotracheal tube is non-invasive ventilation. So there are various modes of these ventilations that we will discuss in coming topics. So in the earlier years, so there was something called as negative pressure ventilation, wherein the patient or a child used to be placed in the drum and the diaphragm used to move. So because of the negative pressure that is created outside the body, lungs used to expand, the chest used to expand, and that is how patient used to breathe. This is a mode of ventilation where there is endotracheal tube is not used. So this is a negative pressure ventilation, which is non-invasive in nature. But it has lost, it was only in the beginnings in 1930s and 40s, and when it was in a experimental mode. Now, after that, we have almost 5-6 decades for a duration of so much time, we have been using invasive mode of ventilation, wherein the endotracheal tube is placed into the lungs and ventilation gives the pressure and flow at specific FiO2s. That is how ventilation was going on. Now, because of the various reasons, the non-invasive ventilation the focus has been shifted to offering same kind of pressures or flows or FiO2s without the need of use of endotracheal tube directly through the nose, which is called as non-invasive positive pressure ventilation. So if we have to classify this, it is classified mainly on the constancy of the pressure. If pressure is constant, it is called CAP, constant airway pressure mode of ventilation. When the pressure is variable, then it is called variable airway mode of ventilation. So in constant airway pressure mode, we have nasal cannula and Cpap. So nasal cannula, I'm very sure most of us must be using in our wards or emergencies or even in ICUs. Nasal cannula can deliver two types of oxygen supports. One is low flow nasal cannula. Second one is high flow nasal cannula. So as a norm, we know high flow means anything which is more than 2 liters per minute flow. So why this division of low flow nasal cannula and high flow nasal cannula is made? One is when the air is flowing into the nostrils and in the upper airway and to the lower airway, there is a whole lot of systematic mechanism wherein the humidification is offered to this air. Without humidification, we cannot survive. The air, if it has to reach from the nose to the alveoli, there has to be substantial amount of humidification to the tune of 80 to 100%, which has to happen. Otherwise, all these ciliated, all these cilias which are there in the airway, they actually have to be moistened so that they tend to move like oars to push away the mucus or to push away the foreign bodies out of the airway so as to protect. So these are kept in movement or kept in action only because of the fact that there is good amount of moisture that is offered by the air, and 90% of the humidification happens in the nose, and remaining 10% happens in lower airways, from the nose to the airways. So these things, these mechanisms, which are the protective mechanisms, which are there, they are lost if there is no humidification, and then child ends up in pneumonias. And it is said that 20 minutes is sufficient to cause damage to these ciliated epithelia, or in fact the cilia per se. So if the nose is offered with a flow of air which is less than 2 liters, there is substantial amount of capacity or reserve in the upper airway to cause the humidification. Beyond 2 liters, the upper airway do not have sufficient amount of reserve, or in fact, as the air goes very fast, a large amount of air goes, there is no sufficient time for the upper airway to offer humidification, which is why we need to have additional support from outside, wherein maybe like humidifier from outside, wherein we are offering humidifier air, and then it is going into the lower airway from via the upper airway, which is why we have this separation of low flow nasal cannula and high flow nasal cannula. The concept behind this remains on the fact that there is a requirement of humidification, additional humidification whenever the airflow is more than 2 liters. And additionally, if we happen to see the caliber of the prongs for HFNC and LFNC, there is a good amount of difference. Now we'll discuss about which later. Coming to the constant pressure, the other modality is Cpap, wherein we have in Cpap again we have constant flow Cpap and variable flow Cpap. Constant flow Cpap actually means the flow of the positive pressure is continuously applied both during inspiration as well as during expiration. So in variable flow Cpap, the resistance, or we can say the air pressure, is offered during inspiration and not during expiration, which is going to make this whole device a child-friendly device. And then we have constant flow CPAPs, in which we have bubble CPAP or the conventional CPAP, which we give through ventilation or ventilator machine. Coming to variable airway pressure modalities, wherein we have non-invasive positive pressure ventilation, and then we have non-invasive SIPPV, and we have BiPAP, nasal BiPAP, and nasal high frequency ventilation. The classification looks here very complex, but in reality things are very simple. As we keep on understanding each one of these, things might things might look very easy. So why are we so worried? Why are we so stressed about the positive pressure ventilation, or I should say the invasive mode of ventilation? It is said that in children, more so in infants and newborn babies, the lungs are so fragile that when we are offering invasive positive pressure ventilation, there is a great chance that the lung parenchyma is going to get damaged, and this damage may and at times be irreversible. And it has been said that single intubation per se can cause bronchopulmonary dysplasias, which now currently is called as chronic lung disease. So, and even a single breath also can cause all these traumas that we know of, whether it is polytrauma, barotrauma, biotrauma, atelected trauma, all these traumas can happen. So in neonatology, more than pediatrics, the chances of the fragile lungs undergoing the damage, which might even eventually lead to permanent or long-term ill outcomes, which is why the efforts to get away from this invasive mode is being made. So when we discuss about CPAP, I mean, there is some confusion between amongst people about what is CPAP and what is PEEP. PEEP and CPAP, they might look same. PEEP is basically offering pressure during expiration. That happens in normal ventilations. And CPAP is again same thing, wherein there is constant pressure offered both during inspiration and expiration. But in CPAP, the baby is breathing by self. So it is only theoretical difference. In CPAP, there is a constant breath, that is when the respiratory cycle that is going to happen with the self effort of the baby. In PEEP, it is basically, as we see in ventilator, it is offered by the ventilator. So it has been said that CPAP is, I mean, it is one modality that we have to be very much well versed, for the fact that we have to preserve the lungs, we have to preserve the lung functions. But almost half of the babies with respiratory distress syndrome in prematurity may fail CPAP and eventually end up in ventilation. Likewise, almost 1/3 to half of the intubated babies or who are low birth weight may fail the extubation to CPAP. In spite of this fact, it is still advised to start CPAP. We cannot say that almost half of the babies on whom we put the CPAP, who are very low birth weight, eventually end up on ventilation, and then so put the babies on the ventilation directly, invasive mode of ventilation directly. We have to give the best effort to make sure that we are offering non-invasive mode. Wait for some time, let the baby respond. If the baby is responding, continue the same. If the baby is not responding, if the baby is requiring more pressures, then we have to hike up. So needless to say about the villi, which is ventilator-induced lung injury. So the volutrauma, barotrauma, atelective trauma, biotrauma, all these things are really detrimental. They not only affect the poor outcome in terms of the bad lungs. Because of this, there might be baby having fluctuation in the intrathoracic pressure, thereby causing fluctuation in the cerebral perfusion rate, and that might lead to intraventricular bleed, intraparenchymal bleed in the brain, and may result in poor outcome. Which is why we have to preserve these fragile babies with as much as possible, with as much as non-invasive mode of ventilation that is possible. So so now moving on, I'll just briefly touch upon the history part, the physiological mechanisms, indications and the contraindications, and practical part wherein I'll try to explain about the setup, settings and weanings, and what is failure. So when we say about non-invasive ventilation, eventually we end up with CPAP or HFNC. So when we speak about CPAP, there is positive pressure, but the baby has to be spontaneously breathing when we are offering this positive pressure. And this positive pressure is constant, and it is happening for the whole duration of expiration as well as inspiration. So throughout the respiratory cycle, it has to happen. So historically, it was initially started in Columbia University by Gregory et al. In 1969. They found out that till 1969, most of the newborn babies were initially started directly on elective invasive mode of ventilation, and outcome was going to be very bad because of all these chronic lung disease conditions of various stages, and because of the infections and VAPs, the outcomes of the babies was not so appraising. Now, Grigor et al. Initially started, and then this thing of concept of CPAP was continued by multiple other researchers, whether it is Catfinkel or Avery. Now, CPAP has become the gold standard of neonatal care. So the mechanism is extremely interesting. It offers its benefit in multiple ways. One is the most important thing that we use CPAP for is respiratory distress syndrome, which was initially called as HMD. wherein where is the preterm lungs are made in such a way that there is insufficient amount of surfactant, and which is why the alveoli tend to collapse. So when we offer certain amount of pressure via Cpap, there is distension of these alveoli, and whatever minimal amount of surfactant that is there within the alveoli, it tends to get conserved and uniformly distributed. So this helps in recruitment of the alveoli. So because of this recruitment of the alveoli, there is maintenance of functional residual capacity that happens. And because of this maintenance of functional capacity, there is good air exchange across the membranes. PCO2 is appropriately removed, which otherwise would have retained in the body. And these babies usually have, initially, if not look well off, then these babies will have hypercarbia and respiratory acidosis. So when we are offering the lungs stability by offering uniform distribution of alveoli, there is improvement in the PaCO2, as well as eventually there is improvement of the pH. Secondly, stabilization of chest wall. This is again very important thing. So imagine in a pediatric population or in an adult population, the rigid chest wall is something which is designed in a way where it is almost like a drum, and the diaphragm, when it is moving up and down, what happens is, because this rigid chest wall offers the stability, and against which, whenever the diaphragm is moving up and down, there is expansion of lung that is going to happen. This is going to help the normal human being, because almost 75% to 80% of the respiration is offered by movements of the diaphragm. So this stability is offered in pediatric and adult population, or even in bigger children. In neonates, or especially the preterm neonates, even the chest wall is also flabby. So when the diaphragm is moving up and down, as a reciprocative movement, this also keeps on moving sideways. So there is no enough amount of lung expansion that can be offered, even with good diaphragmatic movements. So because of which the baby may go into hypoxic state. When we are offering Cpap from the upper airways, this Cpap offers distension and maintains the stability of the chest wall. When the chest wall is made stable, then when the diaphragm is moving, this helps in prevention of this hypoxemia. So this reduces the airway resistance, reduces the work of breathing, improves VQ mismatch, and improves the partial pressure of oxygen. Likewise, it also helps in splinting of the upper airways, which otherwise, because of the prematurity or because of the neonatal status, the airway are also flabby, and they need certain amount of splint to be kept stabilized. And additionally, this is one important thing about stretch of lung and pleura, wherein there is stimulation of stretch receptors and continuation of apnea. So we'll discuss about this part in subsequently, but then we have to know that it helps in stability of splinting of upper airway. It helps in prevention of collapse of the alveoli. It helps in stability of the chest wall as a whole, and it helps in stimulation of the respiratory centers. So what are the indications wherein we use the Cpaps in newborn babies? We use, if I have to tell in reverse order, we use Cpap in delivery room, which is called DR Cpap. Usually when we are offering, if we do not do positive pressure ventilation, even a single positive pressure ventilation, or in terms of the fact that preventing intubation and offering direct Cpap at the time of birth, with this we can avoid NICU admissions. We may avoid surfactant usage. We may avoid the baby going into hypoxemia or respiratory acidosis. We may avoid uses of oxygen. We may avoid long-term poor complications. So delivery room Cpap is one modality which we call it a separate entity, and it is there is separate equipment in delivery room, something like T-piece resuscitator, which can be used for offering delivery room Cpap. And this is not same as the Cpap machines that we use in NICUs. Then pulmonary insufficiency of prematurity, wherein the lungs are not well developed, and there is, great amount of flexibility of the chest wall. So there is some amount of pressure that is required, but there is no pathology in the lungs. There is no collapse or consolidation or obstructions. So this is for just for prematurity, where there may not be a requirement of oxygen, but there is some insufficiency. So we have to offer Cpap. Then airway malacia. So whenever there is airway, something like laryngomalacia, laryngotracheobronchiomalacia, wherein we have to stabilize the upper airway, we may have to offer Cpap. And then post-extubation. So in newborn babies, although we can directly extubate to room air, but it is always good to make sure, especially in the preterm babies, that the failed extubation do not happen. So after the extubation, or after removal of the Cpap, ideally they say that shift to non-invasive positive pressure ventilation. From non-invasive positive pressure ventilation, shift to Cpap, and then HFNC, then LFNC. But non-invasive mode of ventilation, directly we can shift to Cpap, or we can bypass directly non-invasive positive pressure ventilation, directly extubate to Cpap. And then absolute indications of respiratory distress, whether it is because of respiratory distress syndrome, pneumonias, meconium aspiration syndrome, or TTNV, wherein because of the pathology of the lungs, and because we would want to distend the alveoli, we would want to stabilize the lungs, we offer Cpap. And then apnea of prematurity. Many times, my students, they ask, if the baby is not breathing from by self, how are we helping the baby by offering Cpap? These are the babies wherein we have to offer positive pressure ventilation, or intubate these babies, put on ventilator. This ventilator machine will help in prevention of Cpap. How is prevention of apnea? So how is Cpap going to help in apnea of prematurity? So answer to this is that whenever we are offering, there is something called as pneumotaxic center and apneustic center in the brain. So whenever the alveoli are distended with some pressure, they get distended. Within the wall of alveoli, there is something called as J receptors of Pintel, pulmonary J receptors. So when they get stretched, these receptors send indication to the pneumotaxic center in the brain. From there is information coming to initiate expiration. It comes to the lungs, in fact, to the diaphragm and the muscles of breathing, where expiration is getting initiated. So this cycle continues. So basically, we are utilizing this whole cycle of stimulating J receptors, and then inspiration, expiration, inspiration, expiration, the cycle we are continuing, which is how Cpap is helpful in prevention of apnea of prematurity. Now, what are the contraindication of usage of Cpap? So if the baby is not having any respiratory drive, we cannot give. If there are congenital malformation like CDH, if there is CDH, what happens? All the air, good amount of air goes into the airway, but there is certain amount of air which also goes into the stomach. From the stomach, it goes into the intestine. In congenital diaphragmatic hernia, intestines, if they are filled, then these intestines will press on the lungs and thereby compromise on the breathing. In choanal atresia, it is of no use because there is atresia and there is no sufficient supply of pressure from upper airway to the lower airway. Tracheoesophageal fistula, there is a leak that is going to happen and child might have aspiration. So these babies, we may have to intubate electively. Cleft palate, it is ineffective because there is leakage of pressure that is going to happen. And then if there is cardiovascular instability, if the baby is in shock, when we offer Cpap, we are actually preventing the pulmonary venous, IVC drainage into the lungs. So because of which child or baby might further go into shock. If there is type 2 respiratory failure, basically inability to breathe by self, when their PCO2 retention is happening, and pulmonary air leaks, when there is pneumothorax, the chances of success of Cpap is very less. Cpap per se can cause more pneumothorax as compared to the ventilation. So in this setup, we have basically pressure generator, we have this gas source, and patient interface. Pressure generator is something from where the pressure is getting generated, as the name suggests. It can be both continuous as well as variable. And there is a gas source and patient delivery system is there. So the pressure generator can be both from the ventilator and it can be also from bubble Cpap. So we'll discuss about these things. And there is something called as continuous flow and variable flow. Continuous flow, as the name suggests, the pressure mechanism is continuous both during inspiration as well as during expiration. And expiratory limb is not open to the atmosphere, which is why the pressure is within the system. And variable flow, there is one name there is something called as infant flow driver, where there is expiratory limb is open to the atmosphere and the pressure is offered predominantly in the inspiration. The during expiration, baby can breathe by exhale by self without any major resistance. But in India, predominantly we use the continuous flow only. So the interface is the point from where we connect the Cpap to the baby. It can be nasal prongs or nasopharyngeal prongs, wherein we put the prongs into the nose. It's so long, we push it inside, it goes into the hypopharynx, and from there the pressure is generated, which is transmitted to the lower airway. And then nasal mask, I think we must have used, we have nasal cannulas. So various makes of various companies. There is something called as Hudson prongs, Fisher Paykel, which is very famous. Then in the past, Argyll Robertson were very famous. And of all this, most important thing that we need to know is the selection of size is extremely important. The appropriate size of the prong mask or prongs have to be used. Otherwise, it may cause leak. We have to make sure that it is snugly fitting to the nose if it is a mask, or if it is through the nostril. If it is not snugly fitting, pressure will not get generated and it will not get transmitted to the lower airways. We have to make sure sufficient amount of pressure as we have devised is generated and it reaches the lower airway. And there might be tight pressure necrosis because of tight pressures, and there might be damage to columella that might happen. So the nasopharyngeal prong was used in the past. Now currently we do not use. So basically they used to have long prongs of almost 10 centimeters, and they used to put through the nose and push it inside. They used to be very narrow and they used to get clogged very easily, and that at times there is a lot of pressure leakage if it is not appropriately placed, or blockage in the inefficient the process used to happen. Now it is completely out of fashion. Nobody is using it. So this is the mask of Fisher Paykel. This is a mask, and this is the prongs of Fisher Paykel company, which is, I think, New Zealand made company. Then we have Hudson prongs, wherein it is horizontal, and this is made in US. Then we have this Argyle prongs, which was famous in last 15 years back. Now it is nobody much uses in India, and these are nasopharyngeal prongs, which I was speaking about. And this is cannulate. Basically, for preventing trauma, they fix it here. So in the examination, they usually do not ask about the difference between all of these, but it is important for us to understand what is the basic make, what is a principle, what is a mechanism of action, and how can we make the non-invasive ventilation more successful. So there are various sizes, infant sizes and nasal prong size, which are there as mentioned by the various companies. There are various advantages of delivery systems and the disadvantages. Always, now if I have to divide this delivery system to nasal prongs and nasopharyngeal prongs, nasopharyngeal prongs, not very costly, affordable, but very difficult to fixate, and because of secretions and all, it might get blocked and it is off fashion now. We are currently using either nasal mask or nasal prongs. We have this Argyll Robertson, Hudson's, and infant flow driver prongs. In India, predominantly we use Fisher Paykel, and we have to make sure that nursing team is well aware of the things in terms of checking the trauma that might happen because of tight fixation, or even if it is not fixated properly, there might be leak that may happen. Now, gas source. So gas source, there has to be a blender of oxygen and air, and we need to have flow meter with humidifier in place. So this is extremely important when we are offering Cpap. So this is the flow meter, and this is the air blender. The flow in the air comes from here as per the blender. And before this, there is one oxygen source and air source. Blending happens. It goes into the humidification chamber. There it gets humidified, and from there it goes to inspiratory line and through the nasal prongs. And in the nasal prongs, there is pressure that is generated to and given to the lower airways. And when the baby exhales, this air is dipped into water, and this dipped tube offers certain amount of resistance. This resistance is actually transmitted to the lower airway, which is how certain amount of Cpap pressure is uh, continuously given. Now, how do we connect a bubble Cpap? Bubble Cpap is connected by the tubings, as we discussed here. We take the humidification chamber first, then make sure that we attach the inspiratory line to this, and then inspirator line, and there is one more line which goes to the interface through the nasal prongs, which is interface. It goes to the baby. The expiratory limb is dipped into sufficient amount of water, and there are markings here. So we have to make sure that humidity of the gases is well maintained by maintaining the temperature at around 34 to 37. And the expiratory limb is marked at a certain number, and that is centimeters of water. And there has to be FiO2, which has to be set. So this is the basic outline of Cpap settings. Now, what are the settings that we need to make sure should be kept when we are, putting the baby on Cpap? So it depends on various conditions. Initial pressures for RDS, people say that we can go up to 7. There are some studies wherein we have gone to pressures of 8 also. So usually we the common principle that people put is 5 centimeters of water, 5 liters of flow, 50% of FiO2, and keep on titrating. But when the lungs are really stiff, especially in the extremely low birth weight babies, we may go to the pressures of 7. And usually the pressure and FiO2 go hand in hand. So 60% 6, 70% 7, 50% 5 is what people advocate. But again, things have to be tailor-made for the baby's need at that point of time. So now for various situations wherein we have to start Cpap for RDS, we have to start at 5. FiO2 has to be 50%, and pressures we have to increase in steps of 1, and maximum pressure, as mentioned in this protocol of AIMS, it is 7 to 8, but currently the advocacy is to go up to 7. FiO2 increment has to be happened in 5s. If it is 20, 20, 25, 35, 30, 35, 40, it cannot be directly in 10s. So failure of Cpap is called as any situation wherein we are not able to make sure that respiratory distress is persistent or worsening, and partial pressure of oxygen is if it is less than 50. In addition, hypercarbia with PaCO2 of more than 60 despite Cpap pressure of 7 or FiO2 of 80% is the failure of Cpap. Now coming to apnea of prematurity, here there is no requirement of oxygen per se. There is requirement of pressure as a whole. Initially start with 4 is what is mentioned, but usually we start with 5. We start with only 21% because we only want stretching that is required at that point of time. Based on the scenario, pressure and FiO2 increased 5 centimeters or 0.5. And if there are recurrent apneas, if they are happening, then we have to offer positive pressure ventilation. Maybe we have to intubate the child. Then for post-extubation scenarios, we start again at 5. FiO2, we usually keep FiO2 on higher side, keep on titrating as low as possible. So when to increase the pressure? If there is grunting, if there are retractions, and in X-ray, if there are less than 6 spaces that are seen, then we have to increase the pressure. When do you have to decrease the pressure? If there are more than 8 spaces, if they are seen in the posterior rib, then we have to decrease the pressure. It is also seen surrogately by flattening of diaphragm. And how to increase the pressure? By putting inside or outside. I mean, I have to say, the bubble in the bubble Cpap, there is expiratory limb tube. If you're putting in inside, we're offering more pressures. If you're pulling out, we are offering lesser pressures. That is how increase or decrease the pressures. So what is the failure? So normally failure, we know that FiO2 of less than 50%, PaSO2 of more than 60%, worsening of respiratory distress is actually failure. So when do you call it as failure? Whenever there is failure of Cpap, we go to positive pressure ventilation or directly, I mean, which actually means intubating the baby. So before considering failure of Cpap, we have to make sure that airway patency is maintained, surfactant is given to the baby, correct size of prongs is seen, uh, which is snugly fitting. There is no, so that there is no air leak that is happening, and baby is not fighting. At times, baby might fight and bring the circuit out. So how do we wean? We have to wean when these things are within normal limits, which actually means that if PaCO2 is less than 60, PaO2 is more than 50. There is respiratory distress, which is improving. And when we are reducing, FiO2 has to be decreased in steps of 5, 5, 5s, and we increased, and pressures in steps of 1, 1, 1. And we have to make sure there are no episodes of apneas, desaturations, bradycardia for at least 1 day. Usually, if it is for 1 day, if the baby is well maintained, it means that coming days, the lung reserve capacity is good and then baby can sustain well. So there are various trials of weaning, but then it is good to understand that if we go gradually down, then things will be better. Now, various comparisons of various modes of Cpap. Comparison, predominantly, we have to do comparison with bubble Cpap and ventilator Cpaps. Both are fairly fine in terms of outcome, but in terms of cost, if you see, bubble Cpaps we can get in current cost of around 2 lakh rupees, and ventilator Cpaps are very costly, and we may have to have requirement of up to 15 to 20 lakh rupees. So outcome wise, both are same. In terms of duration of hospital stay, duration of NICU stay, outcome in terms of long-term outcome, both are same grossly. But if the baby is worsening, we may directly change the circuit and put the baby on same ventilator, which is not usually possible in bubble Cpap. The standalone Cpap machine are not used now, and variable flow devices are also not currently utilized. So only these two things we need to know of. So troubleshooting, whenever there is no bubbles, that means there is no pressure that is generated. So there is some leak somewhere. This is one indication of our intervention. It may also show that if the prongs are not well fixed, there is also some disconnect. Then we have to make sure that it is well connected to make sure the pressure is generated from the Cpap generator to the lungs. So with this thing we have to, so sometimes baby might cry a lot. We may have to use pacifier and sometimes even chin strap, so as to make sure that baby is well preserved. So usually prongs usually don't stay in place. We have to make sure that nursing care is appropriate and is happening continuously, and the nursing care makes sure that things are well in place. So whenever there is prongs which are disconnected, we have to make sure that it has to be put back. Otherwise, it takes very short time for baby's lungs to go into microatelectasis and sudden rise in oxygen requirement. There might be sudden worsening the respiratory distress and may go into ventilator immediately. So we have to make sure that continuous monitoring happens religiously. The complications of CPAP include air leaks, CPAP belly, sepsis, nasal obstruction, nasal septum erosions. Sepsis is because of the handling of the baby, but otherwise CPAP as a whole doesn't give sepsis. So nursing care, as mentioned, vitals, airway patency, nasal care, orogastric tube have to be seen. Otherwise, orogastric tube, when we place, if we don't place, this is a common mistake that we see. If the orogastric tube is not placed, the abdomen keeps on getting distended, and this distended abdomen per se may cause pressure on the lungs, and there may cause worsening of distress. There is no sufficient FRC uh, that may be generated. So always make sure that orogastric tube in place and abdomen is kept less distended. So I think I'll end up on this. Now I think it is we need to have one more discussion on this to discuss about little more about non-invasive positive pressure ventilation, maybe 10 minutes and 10-15 minutes of HFNC. I think in coming days, if I get an opportunity, I'll be able to discuss to complete the topic. So thank you very much for patient listening.
Sir, opportunity is what we have created, and it is an honor for us that you will be leading neonatal emergency course, which will be starting in September last week.
Okay.
That is an announcement, and formally it will be announced among all the students. There are a couple of questions, sir.
Yeah,
First
yeah.
question is by Dr. Bhaskar Reddy. He says, "Sir, what is the best interface with minimal side effect? Is it Ramsey, or if Ramsey, what is the experience, sir?"
Yeah. Yeah. So, very nice question. So, I've used Argyle Robertson, I've used Hudson prongs, I've used Fisher Paykel, I've used prongs as well as masks, and off late Ramsons we've used. So, what I feel is nasal mask with uh, Fisher Paykel made circuit has been the best in terms of offering sufficient amount of pressure and oxygen. Now, the issue with this is that when we are wanting to transport a baby, it is getting difficult. We cannot transport whole of the Fisher-Paykel system in as a whole because there is liquid, it is connected to a blender which is connected to airflow, oxygen flow things. Now, uh, when the Ramsen is simple prongs, which is flexible, thicker, and when we place, it gets snugly fitted into the nostrils. And it is very handy when we are transporting a baby, whether it is intra-hospital transport or inter-hospital transport. But issue with this Ramsens is that it is not tailor-made for every baby's nostrils. Although there is various sizes in this, we may not be able to get best size. And in situations where we are wanting to give more pressures, Ramsons fails to give more pressures. It is very good, handy, affordable option when we are, giving pressures at lower levels. So I feel best one is currently nasal mask with Fisher Pickle, but inter-hospital transport, affordable scenarios, Ramson plays a very good role.
Sir, second question is what by Dr. Atif Ansari. He says, "Sir, what is exactly flow meter meant for? What is the utility of zero point 0.1 or 0.2 liter of oxygen in Fisher-Paykel CPAP?"
Okay. So flow liter, uh, when it's like a normal oxygen flow liter, then flow meter that we have. So when we are titrating the so it gives certain amount of measured oxygen. So for all CPAP machine, it is said that flow meter has to be at least 5, 6, 7 is what you have to. So beyond less than 5, we should not go. So to know whether it is at level of 5, we use that flow meter. So it is used for maintaining the flow. And what is the utility of zero point 0.1 or 0.2 liters of oxygen in Fisher Paykel? So there is no utility of 0.1 or 0.2 liters. We have to start with 5 liters directly. There is no use. So we use flow meters here. Whatever we are using in India, they are the flow meters which are actually used for routine oxygen delivery, nasal mask or nasal. So they are not the one which are originally given by the companies. The companies give different flow meters. Now we are making it we are tailor making it for our needs. We have to start from 5 and above, up to 7, not above 7. It has to be maintained between 5 to 7.
Dr. Bhaskar Reddy asks, what is exactly definition of low flow and high flow?
Yeah, I think we have part of this we have discussed. So as a definition, it is said that low flow means any flow device which is able to offer airflow less than 2 liters per minute. High flow is any device which is offering flow rate of more than 2 liters per minute. So now in high flow, we know there are many devices, whether it is non-rebreathing mask, or we have this Venturis and Cpap machine, ventilators, and even in fact HFNCs. They are all high flow devices. We have low flow devices like nasal prong oxygen that we use in the wards, wherein we do not go beyond 2 liters. The principle behind this low flow, high flow is the ability of the airway to moisturize or humidify the air that we breathe in. So it is presumed that newborn babies, in fact, the good chunk of pediatric population can humidify for air if it is within 2 liters per minute, that speed. Beyond this, if it is there, the airways are not made to humidify. We cannot humidify that fast flowing air. Without humidification, there is detrimental outcome that is going to happen, which is why whenever we are using high flow device, we have to use humidifier. Without humidifier, we cannot use. So humidifier adds to the cost. So, which is why uh, the concept of low flow and high flow is there.
I think, sir, with this question, there are three more questions. First is
Yeah.
chances of pneumothorax at PEEP 7. How much
Hmm.
time we can have before making decision to start venti?
Yeah, they say highest pressures of pneumothorax, highest chances of pneumothorax happens beyond 7. It is said that 8 out of 100 babies who are on CPAP at 7 will have pneumothorax, and 5 out of 100 babies on ventilator can have pneumothorax. It doesn't happen. It's not very common thing. Pneumothorax will not happen unless we go beyond 7. 7 is very comfortable unless the baby is fighting, or unless the pressure is not well regulated. It doesn't happen. If at 7, if you are feeling that their retractions have come down, if the baby is comfortable, if the respiratory distress is seeming to be getting under control, I think 7 is very safe.
So Dr. Bhaskar asks, how much liter of oxygen is consumed on a baby with CPAP with settings of 55 by 5 for say 24 hours per sir at peripheries?
Yeah. So this is one major issue. I know, I mean, I should appreciate Dr. Bhaskar Reddy for having asked this question, because this question has been framed from the perspective of an entrepreneur. So if you are putting a baby at 50% FiO2 at 5 liters, which actually means that per minute there is 2.5 liters of oxygen getting wasted. And if you multiply this 2.5 into 60 and into 24, so many liters of air goes off. So that's why it adds a lot of adds to cost, lot of cost. So it is difficult, but this is how we have to give the oxygen and pressures.
Other question is new concept of oxygen hood with multiple punctured 1 minute of how much liter of oxygen to be started in this hood.
Okay, so the concept of oxygen offered through the hood has now been obsolete. I know there are some centers which are still using the WHO. recommendation from 2015 onwards, there is no advice to use oxygen for various reasons through the hood. One is excessive amount of wastage that happens. So it is said that we can offer 90% of FiO2 if we are offering oxygen through the hood with both the holes closed. If only one hole is closed, we'll be able to offer 85%. If both the holes are open, then FiO2 comes down to 80%. Now, in neonatal scenarios, what is actually happening is there are very less number of cases where there is only FiO2 which is required. It can happen in pediatric age group where there is only oxygen required and not pressure. In newborn babies, usually only FiO2 requiring conditions are very minimal, which is why it is now not advocated to use the head box oxygen or through the hood. There is excessive amount of wastage of oxygen. That is one concept. Second thing is, as the baby exhales, lot of amount of CO2 keeps on accumulated within the hood, and baby again rebreathe that thing back if there is no continuous flow of oxygen. If there is continuous flow of oxygen, then it gets washed out.
So, Dr. Neela asks, sir, for preterm, is it better to start bubble or machine CPAP? And how to set oxygen liter in hood, sir? I think you have already answered that. And yeah, the question is very much important. What is the right machine, bubble CPAP or machine CPAP for preterm?
Yeah, if it is the clinical, the question is clinical, both are same, which means the outcome of a baby, if whether is on bubble CPAP or ventilator machine CPAP, outcome is going to be same. There are some theoretical perspective wherein they say that whenever there is bubbling happening, it almost creates certain amount of frequency, and those frequencies are transmitted to the lungs, and this has ventilatory protective mechanism. But overall, roughly, if you have to say outcomes, clinical outcomes are same. But if you ask, like Dr. Bhaskar Reddy is asking, as a entrepreneur or as a owner, then the cost involved in machine is very high. And if you are putting a baby on ventilator machine on CPAP, and next time, I mean, Sam, parallelly, if there is one more baby which is coming for requirement of ventilation, then things become very clumsy. We have to remove this baby from ventilator and shift this, and shift the baby back. So usually bubble CPAP is the best, which is why practical reasons we initiate with the bubble CPAP. And regarding the second question, delivery room CPAP, when to start? So whenever there is distress, we have to start the baby immediately on delivery room CPAP without wasting any time. We have seen large number of babies going to mother directly from the delivery room, because of the fact that we have offered certain amount of CPAP. If you're not offering certain amount of CPAP at the time of birth, these babies will come to NICUs, and we have to continue to put the babies on CPAP for 1 day, 2 day, 3 days, and it continues. So that initial, what we say, the adaptation that the baby requires, if you're able to help that adaptation by distending the alveoli in delivery, these babies will have very good outcome, and then can be easily immediately shifted to the mother. So that is how the delivery room CPAPs help.
Dr. P asks, sir, minimum and maximum settings of CPAP, and what are the general precautions on CPAP a doctor should take?
Okay. So the minimal setting, uh, I mean, this depends on the fact that minimum amount of CPAP that a baby can generate by self. Usually babies can generate CPAP by self, they say around 3 to 5 for a term baby. Maybe it is on little lesser side for a preterm baby. So when we are offering pressure, it has to be beyond this physiological point. So we start minimum CPAP setting at 5. We go up to 6, 7. Very rarely, if the baby is large baby, something like 4 kilo, 4.5 kilo, we may go even up to 8. So as a general term, if you want to remember, it is 5 to 7. And the FiO2 has to be in the same percentage. Like if it is 5, start FiO2 50. If it is 6, start FiO2 60. If it is 7, start FiO2 at 70. Usually they go hand in hand. And the flow has to be kept around 5, start around 5. So 5 to 7 is what you can remember. So with respect to the precautions on CPAP, so CPAP is like, it has to be snugly fitted to the nose. Or if you're using prongs, it has to be snugly fitted to the nostrils. If there is any leak, whole system fails. Unlike in HFNC, where we are putting the prongs, and there is around almost 40% gap that has to be maintained, because we are offering large amount of flow and leakage that happens around, from the prongs, that has to be maintained. We have to create a leakage for HFNC. But in CPAP, we have to make sure that they are snugly fitted. And things that we have to see is that there has to be continuity of the whole of the circuit. There should not be any discontinuity, and bubbling should happen. And parallelly, monitoring of the vitals, monitor for abdominal distension. Before that, we have to put a orogastric tube or a nasogastric tube and make sure that there is no abdominal distension, and monitor for vitals, which is very important, because venous backflow through the IVC is hampered because of pressures in the chest. So we have to monitor these things. Otherwise, we can feed these babies. We can, take care of the babies like any other babies. Like we can offer kangaroo mother care also to these babies, and routine things we can continue.
So Dr. Reena Korean acknowledges your excellent presentation and also want to ask, sir, how long do you continue CPAP in the delivery room before considering NICU admission, and what are orogastric tube feeding given, if it is given, and during this time or not?
Okay. Yeah. So, there is no exact time in terms of minutes or hours. The importance of delivery room CPAPs lies in the fact that on how early have we started CPAP. Baby is born. Let's suppose baby is born. Baby comes to the resuscitation space after the disconnection of the umbilical cord. Baby cries, and you notice that there is distress. Promptly, urgently, if you start the delivery room CPAP, chances of this baby recovering immediately is far too high. If there is delay of few minutes, 2 minutes, 5 minutes, 8 minutes, we are causing the damage to the baby. What actually happens is these alveoli, they tend to microscopically, they tend to collapse one by one, one by one, one by one after a cry, first cry. And as they are collapsing, the chances of their recruitment keeps on becoming less and less. We have to offer pressure immediately, make sure that fluid is drained from the lungs, and we offer for a few minutes, maybe 15, 20 minutes. Beyond which, if you feel that respiratory distress is persistent, then we have to, shift the baby to the neonatal ICU. But this is usually seen in late preterms and term babies. When there is distress, offer delivery room CPAP, they do well and go to the mother immediately. And needless to say about orogastric feeds, we do not offer orogastric tubes feedings in delivery room immediately after delivery, because there is substantial amount of glucose that has been supplied, and there is a time space of almost 1 to 2 hours till which we can make sure that baby is well preserved. If the baby is stable, we offer delivery, the immediate feeding. Before that, we do skin to skin care, then offer direct feeding. When we are shifting the baby to the NICU, if the mother is supplying mother's milk, it is good to give mother's milk. If not, we can give the next best milk, which is the donor milk. And least best milk is the formula milk. But overall, the point I want to emphasize, what I want to emphasize is that if the baby is on CPAP or on ventilator, these are not the contraindications of feeding. We have to feed these babies.
Sir, with this we conclude our Q&A, and it was amazing session. I think we started at 7:15, but we ended at 8:18.
Uh,
So I mean, your time was being utilized in the best way possible, and thank you for taking out time from your busy schedule, sir.